Hello, and welcome to the second annual Payer Provider Virtual Summit. This is Vanessa Palmer-Desiato, Project Manager at Excelsior Healthcare Media and moderator of today's session, Blurring the Line Between Payers and Providers. Before moving on, I'd like to take a moment to thank our sponsor, NextGen. NextGen Healthcare is a leading provider of ambulatory-focused technology solutions. They are empowering the transformation of ambulatory care, partnering with medical, behavioral, and dental providers in their journey to value-based care to make healthcare better for everyone. NextGen goes beyond EHR and PM. Their integrated solutions help increase clinical productivity, enrich the patient experience, and ensure healthy financial outcomes. NextGen Healthcare believes in better. We will begin with a presentation by our speakers, followed by a question and answer segment. Audience members can submit questions at any time during the session using the Q&A box on the left-hand side of the screen. A recording of this session will be made available later this week. Today's session will play via your computer speakers, or if you'd like, you can use headphones if those are available for you to plug into your computer. We do not have a dial-in for today's presentation. For all technical matters or difficulties, click the help icon at the bottom of the screen. Now, I'd like to introduce our speakers for today's session, Dr. Betty Rabinowitz, Chief Medical Officer at NextGen Healthcare, Dr. Martin Lustig, Senior Vice President and Principal, NextGen Advisors, and Graham Brown, Senior Vice President and Principal, NextGen Advisors. With that, I'd like to invite Graham to begin today's presentation.
Thanks very much, Vanessa. Good morning, everybody. As noted, I'm Graham Brown with NextGen. We're pleased to be with everyone today and present the opening webinar for the second annual Payer and Provider Virtual Summit. A little bit about myself. For most of my career, I've been a management consultant and advisor to leaders of healthcare organizations, developing strategy and operations for payers and providers in their shift and transition to value-based care. My colleagues, Dr. Marty Lustig and Betty Rabinowitz, are with me today to explore the topic of pay-viders, blurring the line between payers and providers. Perhaps each of you could introduce yourselves to our attendees today. Marty?
Thanks, Graham. Thanks to everyone for joining us today. Just a little bit about my background. I'm a pediatrician by training and spent the first 17 years of my career with Kaiser Permanente, where I was the chief operating officer. The last several years I was there in the Washington-Baltimore area. And then after a couple of years at a small health system in upstate New York as the CMO, I spent 13 years at the Blue Cross plan here where I live in the Rochester, New York area, Excellis Blue Cross Blue Shield. And from there, I started my journey here at NextGen about 2 years ago with Betty and Graham. Betty?
Thanks, Marty. Betty Rabinowitz. I'm a general internist. I was in practice for 25 years at the University of Rochester, the last 5 of which as the medical director for the Center for Primary Care, and then got very involved in data and analytics, left the university to found a population health analytics company that was acquired by NextGen in 2017 and have been NextGen's chief medical officer since that time. Remain very passionate about use of data to support practice transformation and population health.
Great, thanks Dr. Betty, Dr. Marty. So just a little bit about the NextGen Advisors. We work with ambulatory provider organizations on a range of matters that we know are front and center to succeeding under the current fee-for-service reimbursement models, while also transitioning into alternative payment and risk-bearing models. These services include forming organization-wide strategies for patient engagement and access, managed care and alternative payment model contracting support. We work with organizations on their current value-based contract performance and helping them to optimize that kind of performance. And for those with a growing network or a number of locations, or for those organizations that are serving providers across a region, we also help with the development of management service organization capabilities and the programs and offerings in various different markets. So to our agenda for today. In this session, we want to cover what is a pay-vider. We're going to look at some lessons from Kaiser Permanente and other pay-vider organizations and talk a little bit about their background, their recent struggles, and why some of this work is so challenging. We'll also cover some of the success stories that are out there in the marketplace and talk a little bit about how health plans are driving a paradigm shift in how care is being delivered in the United States. We want to start today's session by learning a little bit more about the attendees that are participating. We know we've got several hundred registrants, and so with a couple survey questions here, we're going to get a little bit of better insight as to who's joined us today. Vanessa, could you walk us through those survey questions?
Yes, absolutely. So you should have received a pop-up that will have the polling question available for you to respond to. And the polling question is, how would you classify your organization? Pure payer, payer that owns some provider assets, independent provider, hospital-owned provider, or provider owned by a payer or other, for example, a private equity. Please select the answer choice that best fits you and click submit. All right, let's take a look at those live results.
So we've got almost half of our audience are independent providers here. A big group of hospital-owned providers and other providers. So majority of provider participants today, but also a good cohort of folks that work with payer organizations, including those that have some provider organizations. So that's a really great mix and very helpful for us to understand.
Excellent. Let's go to our next poll question. For providers, what is your specialty mix? Primary care, multi-specialty, behavioral health, single specialty, or health system? Take a moment now to select the one that best fits you and then press submit. All right, let's take a look. Grant?
Wow, very interesting. So about 20% primary care, just a little over 20% multi-specialty. Pretty good mix of behavioral health and single specialty organizations participating today, and health systems as well. So we've really got a good representation of the ambulatory delivery system market. Really nice mix. And certainly all of the provider organizations that are joining today are going to be contemplating and thinking about the world of pay-viders. It's going to have relevance and impact to your organization today and in the future. So it's a good mix for this topic. Why don't we move to our final question here for payers?
Excellent. Yeah, so here's our final question for payers. What is your level of investment in provider organizations? None. Owned provider organizations have little or no impact on overall finances. Owned provider organizations have significant impact on overall finances, or owned provider organizations are critical to overall financial performance. Take a moment and select the answer that best fits you and click submit.
Huh. Interesting.
So interesting indeed, yes. So thus far, about 45% of the payer organizations listening in today do not have any direct investment in provider organizations. And for those that do, it looks like they both represent a significant or critical aspect of overall finances. And this is really part of the balancing act for pay-vider organizations that we're going to be discussing today. So it's interesting that those that haven't moved into the provider space are a large cohort, and for those that do, it's a pretty significant aspect of their overall financial performance. Thanks for sharing some background about the participants today. We appreciate that. Is
just one comment on that before we move on. There's an interesting contrast between the proportion of payers that we see where it's critical to them, their own provider organizations, and yet when we look at our first question, the majority of the plurality of in the audience were independent providers, which means they are not connected to the payers in that way. So we have a little bit of a different mix among the payers than we do among providers here.
Yeah, definitely. As we think about the journey toward value-based care, it's worth understanding the potential end states that might serve as a guidepost. For single specialty groups, maximizing the potential of an effective bundle payment strategy might serve as that endpoint. For primary care groups, it could be a partial or global capitation model. And for large multi-specialty groups, clinically integrated networks or large hospital systems, becoming a pay-vider becomes a realistic possibility. While we think of the word pay-vider, it clearly implies some combination of being both a payer and a provider, but the whole concept can be a little confusing. So Marty, why don't you help us by providing a bit of a definition of pay-vider?
Sure. So I'll admit my definition is probably skewed by my 17 years at Kaiser Permanente. But I think in its simplest form, a pay-vider is understood as a single organization that functions as both the health plan and the provider. And when you think about that from the health plan perspective, it generally means the health plan actually owns the provider network. And from the provider's perspective, the provider that becomes a pay-vider either builds or buys health plan capabilities where they serve as either the exclusive or the primary tier one network for that plan's policyholders.
Mm-hmm. Betty, what are some of the other definitions to consider for pay-vider?
Yeah, I have a bit less of a, lacking Marty's experience at Kaiser, I have a bit of a more holistic view of pay-vider. And in my mind, with the shift to value-based care and advanced payment models, the core of that is sharing or shifting risk from the payer side to share it or transfer it to the provider side. And by definition, in my mind, as soon as a group is participating in downside risk, they have become a pay-vider because they have taken on one of the characteristics that separated out payers in the past, which they were the holders of the actuarial risk for a given population of members. So in my mind, as soon as your group or your practice or your organization has taken on downside risk for a part of your population or a significant part of your population, by my definition, you have become a pay-vider. Your obligations, your interests, your incentives, your disincentives, your world becomes one that is highly impacted by this risk, and we'll be talking about it in a moment. And therefore, I think, in my guess, most of the people on this call are pay-viders, whether they're payers or providers, because they are likely, at least for some part of their population, in two-sided risk.
That's great. Thanks, Betty. Marty, you spent the early part of your career, as noted, with Kaiser Permanente. They're often viewed as the oldest pay-vider in the country. So tell us a little bit about that model and what's unique about them.
Yeah. So I even though I do think this model is based on history, not easy to replicate or necessarily scalable to the whole country, I think it's worth spending a minute or two because I do think there's a lot to be learned from the Kaiser experience. So for those that aren't entirely familiar, Kaiser is actually set up as three separate companies. There's the Kaiser Foundation Health Plan, which is essentially the payer, Kaiser Foundation Hospitals, and the Permanente medical groups. And those three separate organizations have what are called mutual exclusivity clauses in their contracts with each other, so that the health plan is only allowed to contract with the Permanente medical groups for their medical care. The medical groups are only allowed to care for Kaiser health plan members, and the hospitals are served by only the Permanente medical group and only serve Kaiser members as well. And so all of those relationships make it essentially have to function as a single organization because no one of those organizations can survive without the other two.
It's very unique model, and certainly, you know, requires a fair bit of alignment amongst these different three organization entities all working in concert together. What does that actually mean in terms of how they operate then? Betty? Or go ahead.
Well, I'll talk about Kaiser first, and then Betty can.
Sure.
In the Kaiser system, alignment has some very practical implications. One of them is that for the providers, they only have one payer, so they only have one set of administrative costs, administrative rules. So whether it's prior authorization or benefit coverage or pharmacy tiering rules, prior auth rules, all those things are pretty consistent because you're only dealing with a single payer. So the other part of the alignment is because of their financial risk base are aligned with each other, so that success for one of those parties is success for all three. So as a result, within the Kaiser system, virtually all of the patient-facing functions like care management and utilization management that in most other organizations lie in the health plan itself, within the Kaiser system, they're able to transfer all of those accountabilities and resources directly into the delivery system, which is creates a much more aligned approach to patient care.
Betty, what would you add to that?
Yeah, the challenge in my mind is that for my sense is most of the groups on this conference today, the world isn't as monolithic as what you described at Kaiser, Marty, and that the obligations that stem from being taking on risk and therefore becoming a pay-vider to a certain extent, the obligations are quite significant. It has to do with the way data flows and the way data is shared between the actual payer and the group in ways that has never been done before or required before. The payers have to share claims and the group needs to develop claims analytics capabilities. The payer needs to have access to clinical data from the group about the population of patients that they are managing jointly. So even if you just look at that component of that relationship, it's a completely new environment that will take learning on both sides, both the clinical group and the payer group. The notion that you can manage risk and cost and quality using only a sliver or a slice of the data, whether it be clinical data that you have or only administrative claims data if you're the payer, is no longer viable, and there needs to be a deep combination of those two types of data. And the other thing is that there needs to be a whole new understanding of attribution and assignment of patients so that both the payer and the group understand very carefully and very well who is being covered, what the rules are of transition in and out of that covered group, so that measurement and actually assessment of outcomes is done in a mutually agreeable and a way that is constructive and helpful.
Yeah, Betty, I'd like to build on the comments you made, because I do think that if you look back at the failure of HMOs in the 1990s and the failure of IPAs, it was precisely because health plans and providers managed those as basically arm's length contracts that were just a different way of contracting to create risk, to share risk, as opposed to actually having transparent sharing of data and leveraging the resources and data infrastructure of both provider organizations and health plans to create value that cuts across and ultimately results in better care for patients. So I do think that's a huge distinguishing factor worth spending time on.
Mm-hmm. So I imagine there's some downsides to this type of model as well. Talk a little bit about those, Marty.
Yeah, well, I'll go back to Kaiser for a minute because it's kind of the pure example of a complete pay-vider system. I think the biggest vulnerability of the Kaiser model is that it's a completely closed network. And it's probably the reason why Kaiser is only in a handful of states in the country, and is because once patients get Kaiser coverage, they can only go to Kaiser providers. And historically, choice for patients has trumped every other attribute of healthcare in terms of what drives their preference for health insurance coverage. So I think that's the biggest limiting factor. There are others, probably worth noting. The Kaiser model is extremely difficult to replicate, I think. The Kaiser evolved over the last 70 or 80 years through much less tumultuous times than what we are living through today. So for a provider organization to start down that path today and try to develop the kind of mutual accountability among those players, major stakeholders, I think is an enormous lift, and there are probably other models that are easier to achieve in today's world.
Mm-hmm. So you raise an interesting point, because Kaiser did develop really in a different era and in a different time. For organizations that are moving into this space now, I imagine there's a different set of challenges that need to be overcome. Betty, speak a little bit about those from your perspective.
Yeah, indeed. When you really think of what the last year or two, especially with the impact of COVID, have brought, if you think of it, the roles of Medicaid have grown by 15% just in 2020. Medicare Advantage is the fastest growing health plan in the nation. And CMS as a whole, with all of its programs, has committed $1 trillion to driving and achieving their policy goals. So there is this huge drive that is impacting healthcare across the country, where organizations and commercial payers are signing up for these Medicare Advantage partnerships or plans or programs, which means that for provider groups, they may find themselves in relationships with multiple Medicare Advantage plans or providers, or trying to kind of get into a single program that they can manage and run, where risk is material, is substantial, and that is, and without the benefits that Marty spoke about with administrative simplicity when it's a single closed network, I think groups are required very quickly to learn some of the new tools and new approaches to managing these populations, because these shifts and changes are happening very rapidly. And there's both risk and opportunities. There are some markets in which there's a tipping, that are at the tipping point for a Medicare Advantage. And there are some markets where there's still a lot of open space, white space, and a lot of opportunity for first movers. But it's going to require significant skills, tools, and a change in approach and attitudes on both payers and provider group sides.
Mm-hmm. Yeah. And particularly, I think, as you mentioned earlier, this sharing of data. Our providers that really want to move successfully into this space have to start to think differently that their data is their data and the health plan's data is the health plan's data. That data needs to come together in a way so that it can be used to drive value. And that can only happen with a much different relationship where both sides are willing to think differently about how they use data and how they do their work, from utilization management to care management, to population health, quality measures. All of those things are on the table to be done in a different collaborative way than what has happened historically.
The last decade's seen a lot of new entrants into the pay-vider space. Maybe talk a little bit about some other examples of different organizations that have moved down this path and what some of their results and experiences been.
Okay, well, I'll start with a couple of cautionary tales. One is the Piedmont Wellstar health plan that was established in Georgia. Those were two provider organizations coming together and then buying or renting the resources to do the administrative health plan functions. Their goal was to have their 35,000 combined employees and dependents covered, as well as offer Medicare. But within 2 or 3 years, they were unable to establish and grow a Medicare population, and they realized they just didn't have the membership to sustain the product, and so they folded fairly quickly. Another example of a really strong delivery system, Inova Health, combining with a really strong health plan, Aetna, in the Northern Virginia area. And they established, again, in both commercial and Medicare, and this was around 2012, I think they started. By 2015, they pulled out of their commercial exchange product. And in 2020, their membership, although substantial at 150,000, it actually declined from where it had been a couple years earlier. So that's an example that is struggling, but still on the path there.
And what about some of the more successful examples? Because there have been those as well.
Right. So the two I would touch on as successes, the first would be the University of Pennsylvania Medical Center, which became the University of Pennsylvania Medical Center Health Plan, UPMC Health Plan. And they have grown in the last decade, so they now have 3.5 million members in Pennsylvania. So they're a dominant force among health plans as well as among providers. So I think a lot to be learned from their success. And in another vein, looking at it on the health plan side, I think the United Optum is a really important part of this story, where in 2010, United formed this subsidiary Optum that today brings in $100 billion a year in revenue. And 2/3 of their revenue comes from United Healthcare, but they also provide services that are contracted with other health plans throughout the country. And it's expected by the end of this year that they'll own over 60,000 providers in the country. So this talk about blurring the lines between health plans and providers, Optimum, I think, is a really bold example of that.
Yeah. Betty, any others to reflect upon from your knowledge and experience in different markets?
Yeah, my sense is an organization that I have kind of followed, and I think they have created some very successful, reproducible models, is Henry Ford in Detroit. They just recently came out with a kind of an innovative approach to a large employer to offer a plan, and have had remarkable results in terms of both patient satisfaction and engagement, quality scores, as well as quite significant reduction in hospitalization, ED utilization, and obviously, consequently, cost reductions. So that certainly is a program that has managed to create some very successful inroads.
there seems to be kind of some different plays that organizations can make in this space. And the Optum approach, really started with an incredible technology and analytics backbone that, as you noted, is being provided to a number of different organizations around the country. What are some of the other approaches that health plans are taking here? Not necessarily becoming providers, but certainly blurring the lines.
Yeah, I think if you look at all the major health plans, the largest health plans in the country, you'll just see they're all moving aggressively into this space in their own way. So, Aetna, we all know, merged recently with CVS and has the potential to use the foundation of the Minute Clinics and CVS to build a hub for Aetna's provider network. In 2019, Humana announced that it's changing its focus from being an insurance company that offers healthcare services to becoming a healthcare provider that also offers insurance. So they've been very explicit about it. And earlier this year, they acquired Kindred Home Health, valued at over $8 billion. It's the largest home health company in the country. Cigna likewise acquired Express Scripts in 2019, and then they recently announced that they're buying MD Live, one of the leading telehealth providers in the country. So you can see across all these huge health plans, big moves towards owning elements of the provider segment.
Mm-hmm. We've got a lot of folks, as we saw at the outset, that are in practice and represent a number of different types of ambulatory practice organizations. So what does all of this mean from your perspective for practicing clinicians?
Well, go ahead, Betty.
No, go ahead, Marty.
I'd say for the individual, the trend towards becoming employed is very much tied to this issue. As these large pay-vider organizations evolve, remaining independent, I think, will be increasingly challenging. And there are a lot of other implications, but I think the other one that I would focus on is that given that it appears that it's already happening and that it's inevitable, that clinicians need to take an active role in shaping the future of these organizations, because if they don't, they will become, many of them will feel like they've become victims of this.
Mm.
To me, one of the main things is for anyone who's been in practice for more than 10 years, there's a shift in perception of the role of the health plan and the payers that needs to occur. To me, I professionally grew up in an environment where the payer was in an adversarial relationship to our group. It was an annual kind of process of messy negotiations, distrust, a sense of if they win, we lose, if we lose, and vice versa. That has to completely shift in my mind. There are truly some great examples where groups have remained independent, which I think, and especially for us as a company that supports a lot of these independent groups, it's really important to shift and to see the payers as partners here. There are skills and capabilities that the payers have that are essential for managing risk and reducing costs that have to be kind of cross-pollinated. There are clinical sensibilities that have to be imparted on the payers. The negotiations have to be from, in many ways, equal parties negotiating, and data flowing freely needs to represent that openness. So the notion that there isn't complete trust is expressed in how the data is shared and should be a red flag in any of these negotiations if there is withholding of data and data capabilities on both sides. So that, in my mind, is quite a significant, just emotional, philosophical shift, because both providers and payers will only thrive if that is the spirit of these partnerships, rather than maintaining the old ways, which were costly and obviously we know what we sowed is what we have, which is unaffordable health care. So
if I can pile on to one part of what you said, Betty, in the how the contracts need to change, I think a signal of significant change is in the governance clause within your health plan contracts. Is there shared governance? How are disputes resolved? The old contracts that had disputes go to arbitration or left things at the sole discretion of the health plan are not going to work in this new world. There's going to need to be shared governance, and that should be explicit how that's done in the contract.
Yeah, and there are even those who say that requiring health plans to perform to quality measures that are relevant to them, just the way that the clinical side has quality measurement and quality metrics, is very, very important. So are the payers adjudicating claims in a certain length of time? Is the data that they're providing free of errors and mistakes? Is attribution both of physicians and patients done correctly? Are there no errors in payment? Are all metrics that in a equal partnership, the payers should be reporting to the providers on when the same time as the providers are reporting on time to first new patient appointment and length of time from discharge to first follow-up appointment and all of the quality measures that we're familiar with. And I think that that's novel. We don't see that happening much at all. Quality is still unidirectional from provider to payer. I would love to see payers to providers being measured on these items, and providers choosing partners who have performed well on these metrics.
Great comments from each of you. We've got about 7 minutes left here, and we've got a number of questions that have come in from the audience. So I'd like us to shift to that for our next little bit here and see if we can address some of those. One of them from Bill is, do you see anyone doing a good job connecting value-based care with value-based insurance design? Also, whose responsibility is it to help bring patients and families into the equation, helping them develop a greater sense of consumerism with a better understanding of the way care is delivered, consumed, and financed?
So I'll take a little bit of that.
Give a start on that.
Yes, I'm sure some of the payers in the audience would be interested in this as well. So as far as the benefit design, first of all, in government programs, that is largely prescribed by the government. Things have loosened a little bit in Medicare in terms of enabling payers in Medicare Advantage to add more benefits. But in terms of exactly how those benefits are structured, there's a lot of regulatory requirements that constrain the way that's done. On the commercial side, in many ways, you have the opposite problem. And that is that in today's world, 60% of people in this country who have commercial insurance are under a self-insured contract where the employer bears the risk. And because of that, the employers are actually not constrained by government regulations and can design the benefits however they want to. And it's part of why providers experience such an incredibly complicated array of benefit designs as they try to navigate these quality requirements and managing costs without having aligned benefit designs. That's a tough nut to crack. I don't see a simple solution for it. The Kaiser solution was an obvious one where you only have one payer. But if you have the majority of employers who are dictating the benefit designs, then from a provider perspective, you have to manage that issue one employer at a time.
My response to the question, who is responsible for patient and family engagement, is in a well-designed pay-vider world, everyone. So both the patients bear some risk and they're responsible for becoming engaged and involved. The providers bear a risk for this level of engagement, as do the payers. I think that that's the winning prescription. The answer is everyone, patients included.
Thank you. I'm going to combine a couple questions here because they're along the same theme. So can public opinion be changed on the virtue of choice, i.e. narrow networks, better outcomes, et cetera? It seems like a big risk in the pay-vider space is exclusive provider networks. And so do you think that employers and consumers will accept limited choice? So do you want to take a stab at that?
Yeah, so some of my experience in this space goes way back to my days at Kaiser, when clearly from their perspective, this is a huge issue, not they've been trying to crack throughout their existence. And most of the research shows that you have to have at least a 15% lower cost in order for people to be, individuals to be willing to change coverage and not have the same choice of providers. That's a big differential in cost to be able to achieve. And I'd be interested whether there's newer information that would change that. I think that holds pretty fast. So I think obviously ability to demonstrate improved outcomes and patient satisfaction are also critical to that. So I'd leave my response to that.
And my sense is there will always remain people for whom choice is a driving factor. And it might be that there will be differential premiums and payments for maintaining choice, whereas the absence of it will be made worthwhile, Marty, as you mentioned, by the differential in cost and excellent outcomes.
We've got about 1 minute, so a quick response. We'll do one more question here. What might happen to health plans that don't move into the provider space? Be interested to see if you think there's some challenges or some writing on the wall in that regard.
Yeah, my quick response is I would, unless they're huge, in which case we see they're all going into this already, I think they're at risk of being pushed aside and made irrelevant in the world to come.
I will say one word: dinosaurs.
Dinosaurs. Excellent.
And I would love at the end to ask you, Graham, to let people know how they can get hold of us, because we have 20 seconds left.
Indeed, and we had a number of questions here we didn't have the chance to get to. You can reach out to the advisors directly by email, advisors@nextgen.com. You can also go to the NextGen website, nextgen.com/advisors, to learn more about our services and our team. And you can reach out to us directly through our website as well, and a message will get to us. Thanks, Dr. Betty Rabinowitz, Dr. Marty Lustig, for being with us today. Really appreciate it. And Betty, final thought you wanted to share?
Final thought, if you're interested in reading our weekly blog, it can be reached at nextgen.com under blog.
Excellent. Well, thanks very much. And thank you, Vanessa, for having us participate in this conference today. We really enjoyed it and hope it was a helpful session for our participants. On behalf of NextGen Healthcare, Graham Brown, thanks for being with us today.
Thank you all. And thank you all for attending this session. We hope you found it insightful and educational. Please note we have many more sessions to go within the Payer Provider Virtual Summit. If you are interested in attending any of these upcoming sessions, click Register for Upcoming Sessions under the resource list. That concludes this Payer Provider Virtual Summit session. Again, special thanks to our speakers, Dr. Betty, Dr. Marty, and Graham, our audience, and our sponsor, NextGen. From the team at the Payer Provider Virtual Summit and NextGen Healthcare Media, thank you all and goodbye.